Thank you very much, Senator King. Senator Budd. Catch your breath.
Feel free to filibuster. Major General, in your opening statement, whether here or able to watch it on the closed circuit, you identify the importance of the relationship between the military health system and the defense logistics enterprise. So should deterrence fail and the war break out in the Indo-Pacific, there are undeniable logistics constraints, particularly given the geography of Indo-PACOM. The logistics of replenishing medical supplies and evacuating wounded service members could make all the difference in reducing service member casualties. You provide a number of recommendations in your opening statement to address these concerns, including a number of reports and studies, so thank you for that. So what can our military health system do in the short term, like immediately, to address logistical constraints, and how can DoD leverage medical innovation to address some of those constraints?
Thank you very much, Senator. I think the most immediate recommendation that I included in my written statement was that whenever we contemplate an operation or we're updating plans, we do a medical feasibility assessment, very similar to the medical logistics, or to the logistics feasibility assessment that the Joint Staff J4 does. We need to ensure that we are informing our combatant commanders about what is and is not possible. That is something that can be done very easily. The longer answer to your question gets back to the discussion that we were just having about partnering with industry, both on the equipment and pharmaceutical side and on the healthcare delivery side. We have the Civilian Reserve Air Fleet that allows us to commit money to ensure that we have industry partners willing to provide aircraft and support when we need it. We have no such analog in the healthcare space, even though we know, as multiple senators pointed out this morning, that there's insufficient capacity in the DoD and in the VA to care for our casualties. The NDMS currently is a voluntary system in which hospitals can say, yeah, okay. And then when we call them, they say, I'm busy today, I'm not going to participate. We actually need to codify a system, as we've done with other industrial partners, in which there's a commitment and an understanding of how the reimbursement would work. The last point that I would make on that going forward is, in supplemental planning for future operations, we have to build in that cost. There is no question, if we're bringing back thousands of casualties, as Colonel Cannon described, that is going to displace care and it's going to increase cost at hospitals. We have to plan for that. That's why this whole planning effort, the Integrated CONUS Medical Operations Plan, for which NORTHCOM is the lead, in partnership with industry, state, local, and HHS officials, is so important, so we can bring back the requirements for funding and the challenges that we'll need congressional help to address.
Thank you. Following up on that, you said we need to codify that. Do you have the language ready, or has that been written in a way that we could review either individually or as a committee?
Senator, I took the liberty of including an attachment with suggested language just in case anyone wanted to do that.
We'll read it in a few moments. Thank you. Mr. Robb, as you know, the department relies on a mix of military personnel, federal civilians, and contractors to carry out its mission. Talk to me about the roles of physician extenders, such as registered nurses, and what role do physician extenders play in ensuring the readiness of the broader force, and what challenges do you see to retention of physician extenders?
Thank you for that question, Senator. I think it's key that what we are the same issues of what I call proficiency and currency that exists for physicians exists for our physician extenders. And the Army does a great job, especially in the way they've manned and equipped their fighting forces of using those physician extenders all the way down to the corpsmen to the fullest extent of their capabilities. And so I would argue, as we have these discussions about medical readiness and about our ability to care for what we call critical wartime specialties, we must remember trauma is a small percentage of that, but the majority of the care that is applied to our fighting forces comes from our primary care providers, in which would be PAs, nurse practitioners, general practitioners, family physicians. So we must ensure that they also have the critical thinking skills and the opportunity to practice at the top of their game.
Thank you all for the whole panel. Chairman?
Senator Budd, yes, indeed, in looking at the statements which have all been admitted to the record by unanimous consent, I see on page 14 of Dr. Friedrich's prepared testimony, attachment 1, suggested National Defense Authorization Act language. So we do appreciate him acting as an uncompensated legislative staffer for this committee. We appreciate that. And thanks for the question.